Hi everyone, and welcome to the next set of slides. This one is specifically to the blood vessels. I will be talking about blood vessels in regards to their makeup and so forth, while I did this week. This set of slides is about getting to know very specific ones that will become integral probably to some of the things you're expected to palpate this semester and both next semester. So you'll see there are a number of arteries on here, and the reason for some of those is because they are palpable that we utilize. Others are just for the fact that they play big, significant roles in the cardiovascular system itself. All right, so you see here in the diagram, I used something similar in class. We're getting a sense here in these diagrams of just how extensive the cardiovascular system is in the body, and how much blood vessels and arteries move through, penetrate, and go around structures to serve the various tissues. So the first one I'd like to talk about is one of the largest, or is the largest vessel in the body, and that is the aorta. It's approximately the diameter of a garden hose, and it rises from the end of the top of the left ventricle and goes all the way down to basically where the umbilicus is. So we say it's the size of a garden hose, where it leaves the left ventricle of the heart. The internal diameter is approximately 2.5 centimeters and the wall about 2 millimeters thick. So it's a relatively thick wall, and as we talked about in class, it is in the presence of a very high pressure system. So we do tend to have a very much larger wall in it to deal with those higher pressures. As it gets down to that point of the umbilicus, it does narrow slightly, but not extensively. At the top, if we go back up to the heart, where it begins is basically at the aortic semilunar valve. Once it's these valves obviously guard blood from wanting to descend back down into the ventricle once the pressures in the ventricle start to lower as the ventricle achieves relaxation. Opposite each of the semilunar cusps is aortic, and the aortic sinus, which is a slight enlargement of the aortic wall because it contains a proprioceptor called a baroreceptor, which is constantly measuring the pressure in the blood itself, sending messages back to the nervous system to suggest any changes that may need to happen. Generally what may happen is if pressure's down, first the baroreceptor may send a message, and the heart will be asked to beat harder to increase pressure. When we work our way down and around, so basically the aorta arises from the left ventricle, goes superiorly to the arch. The arch heads off posteriorly back towards the spinal column, down the left-hand side, and then heads all, as I said, all the way down to the umbilicus. Each of these areas have a particular name depending upon where they are. That being said, then the first portion from the semilunar valves to the beginning of the arch is known as the ascending aorta. It runs, the ascending aorta runs posteriorly and to the right of the pulmonary trunk. It's only 5 centimeters long before it curves into the aortic arch. The only two branches that we have at the ascending aorta are the right and left coronary arteries, which we talked about in class, that do supply the myocardium of the heart itself. There are only two branches, I said, the two branches of the coronary arteries. So we see here in the diagram, these little bumps represent the semilunar valves, first 5 centimeters being the ascending aorta, where then it becomes the arch of the aorta. The aortic arch lies deep to the sternum and begins and ends at the sternal angle. So we're not really talking all that high. If you think of where that sternal angle is at rib 2, this is where it sort of begins, heads posteriorly back, and comes back down again in the arch, is in and around that sternal angle. Off this angle are 3 major branches, or 3 major arteries. The very first branch, as we work from the front to the back, the very first branch is the brachiocephalic artery. If you think of that name, brachiocephalic, it is telling you that this first branch supplies an arm and the head. It passes superiorly under the right clavicle and branches into the right common carotid, which feeds the head, and the right subclavian artery, which will feed the right arm. The next branch, heading posteriorly, is the left common carotid, which supplies the left head, and the next branch behind that, the very last branch in the arch, is the left subclavian artery, which supplies the left arm. Please take note that the brachiocephalic artery is a single artery that then branches just distal to the arch of the aorta to serve both the the right head and the right arm. Whereas the next two branches off the arch don't come off a single and split. They each are their own, the left one heading up to the left head, and then the left subclavian artery supplying the left arm. So we can say then, fair enough, that the aortic arch and its branches supply the head, neck, upper limbs, and part of the thoracic wall. So we'll see here in this diagram, this is the ascending portion here, about 5 centimeters long, and then we start here being just behind the angle of the manubrium and the sternum. The arch comes around behind, then to head back again about the level of the angle of the mandible before it starts heading down. Here is our first branch, the brachiocephalic artery, which I said then branches into the right common carotid to feed the right head and the right subclavian to feed the right arm. The next branch behind is the left common carotid, which goes straight up to feed the left head and some structures in the neck. And then the one posterior to it, the last one, or the last branch on the arch, is the left subclavian, which passes out under the clavicle to feed the left arm. We see it here again with all those structures removed. Here is the ascending, here is the arch with the brachiocephalic, the left common carotid, and the left subclavian. The next is the thoracic or the descending aorta, and it runs along the left side of the anterior vertebral bodies of the spine from T5 to T12. And as I said when I was talking about the vertebral bodies in the thoracic spine in clinical anatomy, it can leave a slight indentation on the vertebral bodies due to the fact that this thing pulsates and pushes on those bodies. The branches in the descending or thoracic aorta is the pericardiac, which feeds structures around the heart. Not the heart itself, that's the coronary arteries. The bronchial branch, which feeds structures around the bronchus of the lungs. The esophageal branch, which serves the esophagus, which is the food pipe where food goes down. And then the posterior mediastinal is to deal with a lot of structures that lie in the posterior aspects of the mediastinum. So we see here, this is the fibrous pericardium here, the ascending, the arch, and the descending, and you see how the intercostals are supplied via this. As well over here, here is the descending or the thoracic aorta here. Here is our subclavian coming off the arch. As we work our way down, we have the esophageal branch here to feed the esophagus, as well a little bit lower, and then we see these intercostal branches as well. The mediastinal branches will be back here in behind to some degree. The last part of the aorta is the abdominal aorta, and there are a fair number of branches that come off of this portion of the aorta simply due to the fact that it feeds a lot of the internal organs that we find in the abdominal pelvic cavity. The branches that come off this segment can be paired or unpaired. The abdominal aorta begins at the opening of the diaphragm, where it remains at the left side of the vertebral body. So if you remember, there is the aortic hiatus as part of the diaphragm. This is where the aorta passes through and is very close to the vertebral bodies on the left side. As I said earlier, the abdominal aorta terminates at the point where the aorta bifurcates, meaning that it divides into the two iliac arteries, right and left, which will go on to feed some of the structures down at this deeper area of the abdominal pelvic cavity, but more or less to go down and feed the lower limbs. Some branch off anteriorly, these branches, while most branch off laterally to the left or the right. So we'll see here in the diagram, we do have pairs and unpairs. So we have the celiac here, superior mesentery, and the inferior mesenteric. These feed structures in the mesentery and some of the abdominal cavities, organs. These are unpaired. Whereas when we look here, we have the suprarenal, which means above the kidneys, right and left. We have the first lumbar, right and left, so they're paired. We have the renal arteries, which bring blood to the kidneys, both to feed the kidneys and to clean the blood. That's where the production of urine comes from. They are paired laterally. And then we have the gonadals, right and left, which feed, gonads meaning sexual organs, so goes down to feed various components of the sexual organs, male and female both. Here are the two common iliac arteries here that will go on to feed down the lower limbs. And then we have the median sacral here that feeds some of the lower organs down into the bottom of the pelvic cavity. The next artery I wish to talk about is an anastomosis, and I know I talked a bit about this in class, and it basically has to do with the fact that an anastomosis is where arteries come together and they interwork with each other, which allows a much more vibrant, connected, accessible vessel system for arterial blood. So this circle of Willis is an anastomosis that is found in the base of the brain. It is made up of 5 pairs of arteries to ensure that the posterior part and the anterior part of the brain's blood supply are united, thus results in a fast amount of the brain being supplied. It also does ensure that if one of these becomes occluded, that blood supply could move in from another area of the anastomosis. The origins of this anastomosis arise from the pair of vertebral arteries. If you remember correctly, those arteries pass through the foramen transversarium in the vertebral vertebra, and the pair of internal carotid arteries which run deep in the neck. Those vertebral arteries unite at the caudal border of the pons, which is a part of the lower brain, to form something called the basilar artery, which gives off a number of paired branches to divide into the 2 posterior cerebral arteries. So we see here are the 2 vertebral arteries here arising from either side of the C-spine to come together, which we see here in the anatomical model. So these 2 will be heading down through those foramen transversarium, and they form this basilar artery, which is this part here running in front of the pons, and it has branches off there feeding various areas of the lower brain. The vertebral basilar arterial system supplies the posterior circulation of the brain. There is a branch off of each posterior cerebral artery that travels to the internal carotids, and it is called the posterior communicating artery, of which there are 2. So here is the posterior communicating arteries are here and here coming off the branch. So they're running between this basilar artery and the 2 vertebral arteries to form up an attachment with the 2 internal carotids, saying that these 2 internal carotids and these 2 vertebral arteries are the basis of this anastomosis. There are also 2 branches off of each internal carotid, the ophthalmic artery and the anterior cerebral artery. So the ophthalmic artery is here, we see here, and the anterior cerebral artery is here, forming an anterior anastomosis between the right and left carotids. There is also a branch which connects the 2 anterior cerebral arteries, which is called the anterior communicating artery, which we see running right here. So all in all of these vessels, all interconnected, create this massive anastomosis at the base of the brain with, as I said, the 4 major vessels contributing being the 2 carotids and the 2 vertebral arteries. The anterior cerebral arteries supply most of the medial and superior surfaces of the brain in the frontal pole. The middle cerebral arteries supply the lateral surface of the brain and the temporal pole, and the posterior cerebral arteries supply the inferior surface of the brain and the occipital pole. So which we see here in real time with its branches heading off to supply the various areas of the brain. This is a cadaver that has had a particular waxy substance injected through the vessels, which allows those vessels to become colorized. So we get a really good sense of just how significant this vascularity is to the brain. So here are our 2 carotids, here and here. Here are our 2 vertebral arteries, here and here. And this area here represents the pons. Therefore, we can say that the cerebral arterial circle, or the circle of Willis, is an important anastomosis at the base of the brain between the 4 arteries that supply the brain. So we have those 4, plus we have the posterior cerebral arteries, the posterior communicating arteries, the internal carotid arteries, the anterior cerebral arteries, and the anterior communicating arteries, all giving rise to more and more numerous smaller branches to the brain, all of these coming together to create this massive anastomosis feeding all aspects of the brain. The next is a vessel that you probably are familiar with because you've been utilizing it when you've been looking at doing blood pressure and so forth. The thing you need to realize when we name a vessel, it could be the same vessel, but because of where it's running or where it is in relationship anatomically, the name will change. So we say here that the brachial artery is a continuation of the axillary artery, which was a continuation of the subclavian artery. So if we go to the right side here, remember we had the brachiocephalic artery coming off of the arch of the aorta, which then further divided into the common carotid that will go up to the head and the subclavian. As the subclavian passes underneath the clavicle and heads out towards the arm, it first becomes the axillary artery because it's passing through the axillary portion of the body, and then to become the brachial artery as it heads into the brachium, which is the upper arm. So therefore, we can say the brachial artery begins at the distal border of teres major, which is a muscle that comes off of the scapula, and terminates by bifurcating or dividing into the ulna and radial arteries just distal to the bend of the elbow. So we see here in the diagram, this is the axillary artery here. It's passing through the axillary area. As it comes out underneath coracobrachialis here, it then is known as the brachial artery as it passes medial to the long head of biceps and slightly underneath. As it travels down, it becomes slightly more superficial to bifurcate just past the bend of the elbow here to the radial and the ulnar arteries. So when we're doing blood pressure, this is the artery that you are palpating. This is the artery that you're also trying to occlude when you inflate your cuff. This area here at the distal biceps is where we try to put oh, for heaven's sakes. Anyways, to listen to the blood pressure. We also see it here in this diagram. Stethoscope. We see it here in this diagram as well. The brachial artery traveling down, bifurcation just past the bend of the elbow. We can see here there's a lovely anastomosis here that surrounds around the elbow joint as well. So we took down the brachial and we said it bifurcated just distal to the bend of the elbow. The first division of that bifurcation we'll talk about is the radial artery. So it is the smaller branch of the brachial bifurcation, so a little bit smaller than the other side. And the reason why we use it as a pulse is because there's no bend. It is what's called a direct continuation. So it doesn't bifurcate off to the side. It's actually a straight line with the ulnar bifurcating off to the side. So because of this direct communication down through, this is why we use it for the pulse. It enters the wrist on the lateral side, where it bifurcates into a superficial and deep branch with anastomosis with the ulnar artery. The ulnar artery is the larger branch of the bifurcation, but not quite as direct, coming off the brachial. It passes along the medial border of the forearm into the wrist, where it too bifurcates into a superficial and deep branch, where it anastomoses with the radial artery. The anastomosis, which is created by the radial and the ulnar arteries, is known as the palmar arches of the hand. So we see here, this is the brachial artery coming down, bifurcating here into the radial artery and the ulnar. Radial smaller but more direct, passing deep to the flexors, coming out distally just prior to the wrist, where it divides into a deep branch and the superficial branch up shorter. The ulnar is thicker, comes down underneath as well, and it passes through to the wrist. Again, the same as the other, dividing into a deep branch and a superficial branch. Both the deep and superficial branches of both the radial artery and the ulnar artery come together to form these anastomoses. Sorry everyone if that seemed to lose a little bit there. I had someone at my door. I'm talking in the office. So to repeat, with the brachial artery here, bifurcates into the radial artery and the ulnar artery. Both the radial and the ulnar divide into a deep branch and a superficial branch, deep branch, superficial. They join together to form two anastomoses. Both the superficial branch and the deep branch come together to form these palmar arches. Remember the other night in class, I occluded both these arteries, had the hand flush out of blood, turning it somewhat light in color, releasing one side, and seeing how the blood filled up the hand, and compared the radial artery to the ulnar to see if there was anything going on between the two. It's known as the Allen's test. The next artery I want to talk about is called dorsalis pedis. This is basically the dorsal artery of the foot is what it means. And this artery is the major source of blood supply to the foot. It begins midway between the malleoli. The malleoli are those two bumps that make up the ankle. And it runs in an anteromedial fashion. It runs between two tendons, the extensor hallucis longus, that should be ICES, I apologize. So the extensor hallucis longus, hallucis means great toe, and the extensor digitorum longus tendons, so it runs between extensor hal longus and extensor digitorum longus on the dorsum of the foot. So the extensor hal longus extends the big toe, and the extensor digitorum longus extends all the other toes. Runs between those two tendons. As it passes to the first interosseous space, which is between the first and second metatarsals, it divides to go into smaller branches to feed the foot. As you come across the top of this interosseous space, this is where we palpate for a pulse. Dorsalis pedis gives us a good pulse. So it's said here that this is a palpable pulse and is a common artery that is evaluated to measure vascular sufficiency to the foot. Now, a couple things about this artery. One is, some people have silent ones. And if they do, it tends to be bilateral, which means you can't hear it or feel it. Also, it's not unusual in the hospital if we're trying to see if someone's arterial sufficiency to the foot is good or not good. To find the pedal pulse, what they'll do is they won't palpate it with their finger, but actually use kind of like a microphone machine that's very sensitive to see if they can hear the pumping of the blood through the artery. So we see here in the diagram, here is extensor hal longus, here is extensor hal longus, and here is dorsalis pedis running between the two tendons. And then as it moves forward, it is running into the interosseous space between the first and the second metatarsals. And this is the area where we do the pulse. Here too is the artery without the bones, all the bones present, and the tendons of the muscles. So the dorsalis pedis is a continuation of another artery called the anterior tibial, but you can see it passing between the tarsals and the first and second metatarsals. And this is where we would palpate for a pulse. We're going to leave arteries now and go into the veins, because there's a couple of veins we just need to talk about. So there are two major veins that, as we talked about the other night, that feed into the heart. The first is the inferior vena cava, which collects most of the venous blood from organs inferior to the diaphragm, as well as collecting blood from the lower limbs. It passes through the diaphragm. Remember, there was a hole in the diaphragm for the vena cava to pass through to enter into the posterior heart at the right atrium. So we see it here, coming up from underneath to enter at this point here in the atrium. This is a picture of the inferior vena cava below the diaphragm to show you the various branches that are there. A lot of them very similar, almost twin-like to the aorta. The one thing I want you to take note of is the aorta runs down the left side of the spinal column, whereas the vena cava comes up on the right side of the spinal column. So aorta on the left, vena cava on the right. The superior vena cava, it receives blood from the tissues and organs of the head, neck, chest, shoulders, and upper limbs. It too connects to the posterior aspect of the right atrium, but at its superior portion. So here we see the superior vena cava here coming to the posterior aspect of the heart, dumping into the right atrium here. This is a picture of both the inferior and the superior vena cava with the heart removed. And we see the vast network that feeds into both the inferior and superior vena cava that eventually dump their blood into the right side of the heart to be reoxygenated. A couple of other veins we need to think about, and that are veins that are returning blood down to the heart from the head and the face. There are two of them. There is the internal and the external jugular veins. The internal jugular vein starts at the jugular foramen, which we know is in the base of the skull, in the occipital bone, which descends parallel to the carotid artery. So the internal jugular runs parallel to the carotid artery, but much more superficial. And basically, it receives blood from those cerebral sinuses that I talked about previous. The other one is the external jugular vein. It is considered a superficial vein of the head and neck. The facial vein also drains into the external jugular. There is an anastomose between the internal and external jugular veins at the angle of the mandible, which provides dual venous drainage of the face, scalp, and cranium. Now, I must say that this anastomosis at the angle of the mandible is underneath it, not on top of it. The external descends towards the chest, just deep to the skin on the anterior surface of the SCM. So the external jugular vein does lie under the skin in front of the SCM. So you could be possibly palpating it when you're working on the SCM. We see it here. Here is the external jugular running in front of the SCM here. Here's the internal jugular running in behind, but running parallel to the carotid artery. We see it here with the arteries removed. Here is the internal jugular here running deep. The carotid would be here as well, deeper obviously. And here is the external jugular vein here that would run between the skin and the SCM. The next are the two major veins in the legs. I have a reason for bringing these up simply because they tend to be the unfortunate site for a lot of varicose veins. And also they, depending on the state of they're in, could also be used for doing bypass surgery in the heart. So the great saphenous is the largest of the two. It ascends along the medial aspect of the leg and thigh, draining into the femoral vein near the hip joint, whereas the small saphenous arises from the dorsal venous arch and ascends along the posterior and lateral aspects of the calf. So here we are. We've got the great saphenous, which is running here along the lateral interior part of the leg, and then we have the small saphenous, which is running behind and dumping into the small saphenous dumps into the lower parts of the deep vein, whereas the greater goes much longer. So the reason the difference between the name of the two is small just means it's not as long, and great means it's the longer of the two. If we remember when we were talking about veins in class, so one of the specializations we had with the tunica intima was the specializations of valves which prevented blood from heading back down into the vein where it came from. There are times when these valves do become a bit damaged and don't work so good, and it results in a bending, tortuous look in those veins called varicose veins. So varicose veins are the result of the weakening of the walls of the veins near the valves that have weakened or become stretched and distorted. The valves may not work properly. Blood then ends up pooling in that area. Remember, it's low pressure. It's not like it's driving back and there's nothing pushing it back. So it tends to pool or remain static or stasis, and the vessels become grossly distended. Another form of a varicose vein that you may not realize, and that is what we know as a hemorrhoid. You can get varicose veins in and around the anus, and that has to do with pressures from either having children or working too hard to go to the bathroom, and that does slight damage to those veins, and then it ends up that they get congested with blood, and they tend to hang out to some degree and become itchy and irritated simply because they're full of this static blood. So we see here in the diagram, this is a picture of an individual who has fairly significant varicose veins. You can kind of see how the veins are broken down, and you have all this blood pooling in the legs. So this is an example where we see the lovely valves working well, keeping the blood moving upwards in the leg, and then the valves through maybe the widening or the thickening or the weakening of the valves, we end up with these large big pools of blood that are collecting here. We also see the same thing in this diagram, sort of showing again how the valves tend to be problem areas, and it results in what we know of as varicose veins, which can occur on the thigh, down the leg, and so forth. Thank you for listening, and these will be on the upcoming tests and quiz. Thank you.